Hi everyone, good Wednesday afternoon and welcome to GoLocal Live for Smart Health. I'm GoLocal News Editor Kate Nagel. I'd like to welcome in my guest from the Warren Alpert Medical School at Brown University, Dr. Jake Kurtis, Chair of the Department of Pathology and Laboratory Medicine. Dr. Kurtis, thank you for joining us today.
Thanks so much for having me.
Well, I appreciate your taking the time to come tell folks who are viewing right now or after the fact what you have been working on, specifically a breakthrough for a vaccine as it pertains to malaria. Now, you are Brown University through and through, though, so I really want to start, as we're here in Providence, about your journey starting at Brown that has come full circle back to the university.
Right, yeah, I've actually finally got them paying me. It took an awful long time. But yeah, so I did my undergraduate, my graduate, and my MD training at Brown. And much to my wife's chagrin, I only applied for one job, and thank God I got it, and was able to come back to Brown on their faculty in 2000.
But let's talk about that pivotal moment when you were an undergrad in Kenya as it pertains to, again, your line of work and your own experience with malaria.
Sure. So Brown, as I'm sure many of the viewers know, has a very open curriculum. It's so open, in fact, that you can nearly kill yourself with it. And so I was doing an undergraduate junior semester abroad, and instead of going to Prague or Rome or Vienna, I ended up going to Kenya, and really had some remarkable experiences there that sort of were formative in my entire career. And one of them was learning about research and doing research projects for the very first time. It was coral reef ecology. But another was actually being lucky enough, and I use that word carefully, lucky enough to contract malaria. And so the juxtaposition of getting a particularly nasty case of malaria and falling in love with research and waking up and realizing that malaria is one of the primary reasons development has not been as fast or as thorough and as widespread as we would hope it to be in sub-Saharan Africa. So I think that constellation of events really propelled me on in a career in malaria vaccine development.
So when you were there as that junior, as that young strapping college student, you knew there was this potential. You brought some medicine with you, but in the back of your mind, did you really think that there was a potential that you were going to contract malaria?
You know, I knew it was a possibility. Back then, we had drugs to prevent malaria while you're traveling, but even then they weren't very effective. So they were already had drug-resistant parasites. And it turns out the travel physician that I went to see before I left, his name was Dick Olds, told me, if you ever have a fever, open up these 3 pills and take them. Fortunately, I did that. He ended up becoming my PhD advisor when I came back to Brown. So he kind of saved my life. I hate to give him credit for it, but it's true. And hopefully we'll be able to actually attack this problem in a more sophisticated way than trying to just take pills. We desperately need a vaccine.
And I think you kind of just did a quick little leap over getting a fever, taking some pills.
Yeah.
But what was it like to actually have malaria?
Yeah, so it was pretty awful. So, malaria, it can be as mild as a simple cold, or it can kill you in 24 hours. It has a great spectrum of potential disease phenotypes or constellations of symptoms. I had something called cerebral malaria, which is where the parasite blocks the blood flow to your brain. It has a case fatality rate of about 30%.
Oh, goodness.
And in those who survive, many are left with neuropsychiatric sequelae, and I think you might agree I probably suffer from some of that. So no, really, I'm using a little bit of jest. It's a significant killer. In fact, malaria in general is the most important single agent killer of children on the planet. Nothing actually comes close to it.
Do you think, and I know we talked about this, do you think Westerners, do you think Americans, folks who might not travel in certain parts of the world, have an understanding about its impact on communities where it continues to persist?
I don't think so. What has helped, and this is a bizarre juxtaposition I'm going to put together here, what has helped the sort of Western view of these diseases has been Ebola. And so people see Ebola and they go, holy crap, this is a significant problem. What are we going to do about it? And they're worried about it because it can land in an airplane right on our shores. And every hospital during the last epidemic had to prepare Ebola plans. So that has opened our eyes to tropical infectious diseases. But I submit to you that Ebola has killed tens of thousands. Malaria kills tens of thousands every week. We're talking about 500,000 minimum children under the age of 5 dying every year. It's one child every 15 to 60 seconds, and it's been doing it for millennia. So Ebola first crept out of the forest in the 70s, maybe in the 50s, depending on how far back you go. Malaria's been killing like that, a great culling machine, for tens of thousands of years.
And how does it continue to persist, Doctor, in such a pernicious
Yep.
manner?
Yep.
Obviously, your life's work focused on it, having such an impact on populations around the world. I mean, how does it continue to be such this killer?
Yeah. So it's a juxtaposition of climate, political landscape, and poverty. You need warm tropical climates for the mosquito to breed effectively and for the parasite to live inside the mosquito. You get the disease when a female mosquito bites you and injects some of the sporozoites. So you need mosquitoes. You need a lack of political will insofar as, we could eliminate malaria if we had the right tools and if we had the right willpower. So we had malaria in this country, in Florida and Louisiana and other parts of the South, and that got eradicated in the 50s. And that was a concentrated program of a good drug and, at the time, an effective insecticide. Now, the mosquitoes are resistant to our insecticides and the parasites are resistant to our drugs. So we need new tools.
And so let's talk a little bit about that. I know I said earlier, in that layman's term, if you will, again, your life's research, looking at a breakthrough vaccine.
Yeah.
So for the average person watching from that scientific perspective, how did you approach it and say, this is the way that we are going to try to look at malaria from a vaccine perspective?
Yeah, so we took a different approach. So there have been malaria vaccines for the last 5 decades. No rodent, no mouse need live in fear. They work beautifully in mice. The translation of protecting mice to protecting humans has been really poor.
Okay.
And most of those vaccine efforts they've sort of initiated studying mouse malaria. When we got involved in this work, we looked at the history and said, wow, starting with a mouse doesn't seem to make a ton of sense. So we actually start with humans. So we're sort of fans of mankind. We actually start in villages where kids have lots of malaria. And when you go into these villages, mostly in sub-Saharan Africa, dominantly in Kenya and Tanzania, what you'll see, some children are resistant, some children aren't. And the question is why?
Okay.
And the kids, what's really interesting, the kids aren't always resistant. They're all susceptible when they're very young, and then some get resistant and some don't. So we try to ask immunologically, what's the difference between these two kids? And can we make the susceptible kids look like the resistant kids immunologically? So that's sort of the big picture of what we're trying to do.
And so, as you said, right now, at the very nascent stages of looking to get it into trials, talk with us a little bit about how that process works and where you're at currently.
Yeah, so it's excruciating. It's like bloodletting. So we have gotten to the point where we have identified malarial proteins that are recognized by antibodies that only resistant kids make.
Okay.
Susceptible kids don't make these antibodies. And we think one of the reasons these kids are resistant is because they have antibodies to these particular malarial proteins. We can make them in great big vats in our laboratory using recombinant DNA technology, and we can use those malarial proteins to immunize as a vaccine non-human primates. And we've done that. And then we challenge those non-human primates with real-life malaria, and they have a significantly less disease and significantly less malaria infection. So we've gotten through the non-human primate phase, and we're really gearing up for phase 1 trials in humans.
And what does that look like moving forward again for folks? As you said, it's like bloodletting.
Yeah.
You're like, this is what you're working towards.
Yeah.
But for the average person who has no understanding about the process.
It is tough. So you first have to gather enough financial resources to do this. To do a trial like this, we're talking about somewhere between $5 and $7 million.
Okay.
Option number one is you've got to raise the money. Typically, NIH steps in, but oddly enough, NIH is much more focused on the very basic work, much less so on the translation. What we need is pharma to come across, big pharma. The problem is we're a little early for big pharma.
Okay.
So they call this the valley of death. This is where good ideas go to die. And so this is typically where venture philanthropy gets involved. So the first thing is to raise the money to actually do the study. Then you've got to make your vaccine in what's called GMP, or good manufacturing process, or basically you have to make it as a clinically pure enough product to put into a human.
Okay.
Then what you would do is you'd enroll typically 10 to 20 individuals, and you'd vaccinate them with your vaccine or a control and do nothing else. That could happen right here in Rhode Island. right here at one of our affiliated hospitals, clinical research centers, for instance. Once you vaccinated these individuals, you take their serum and you see if it kills parasites in culture.
Okay.
And if it does, that's a very successful phase 1 trial.
And so that's very interesting. You talk about the potential for it to actually happen here. So could there potentially be some point in time where you are looking for research subjects?
Oh, absolutely. I sincerely hope that happens here in Rhode Island. There's a complex conversation about should you do your first testing in an endemic country or should you do it in a non-endemic country. Very complicated, and you can make arguments for both.
Okay.
I think for a phase 1 study, it makes more sense to do it right here because we have a good readout on efficacy, i.e., does the serum of the vaccinated person kill malaria parasites in culture? And we can do that all right here.
So you talk about being right here, again, that full circle
Yeah.
coming all the way back to Brown. Really want to put that Warren Alpert Medical School in focus.
Absolutely.
Why, in your estimation, is this the place to be in this line of research with the teams that you are working with in terms of what you've identified? What has the medical school enabled you to be able to do to move this forward?
Yeah, so I feel somewhat qualified to answer that question because I've been at Brown literally since I started my undergraduate in '85. And so I've seen the organization for a very long time. We're at a unique moment in Brown's history. And we're unique because we have, I like to think of it as a holy trinity. You've got a president, a provost, and a dean of medicine that are absolutely all on the same page in terms of advancing the medical research infrastructure and clinical care here in Rhode Island. You've also got a chancellor who's fully on board with that program. That's allowed a number of innovative things to take place. The new growth in the Department of Pathology that I've been very fortunate to chair for the past couple of years, we're bringing in amazing researchers. This is the kind of work you can't do alone. You really need to partner with many different individuals, and this has allowed us to attract that talent because of the investments these individuals have made right here in Rhode Island. So I think it's an exciting time to be here at Brown.
Well, it certainly is, and we appreciate your taking the time to come here. Again, sharing with viewers, sharing with readers what's taking place. And again, when things transpire moving forward, hopefully we'll have the opportunity to talk with you in the near future.
I would love to come back.
Okay, Dr. Jake Kurtis, thank you so much
Thanks so
for
much.
coming in. And
Appreciate
don't go
it.
anywhere. We're going to be talking from medicine and academia to politics here on GoLocal Live. We'll be right back.